Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you. I know last time we were wanting to go over more of the actual antidepressant medications themselves. So today I'm kind of going over some of the first-line antidepressants, and as well as I'm going to try to also go over some of the newer ones if we have time, because I know that these newer ones are coming out and everyone's like, well, when do I use this and what's kind of the story on it? So, yep, no conflicts. Obviously, data in the presentation offers a limited perspective on how systemic, social, and economic factors impact health. We do recognize that racism, not race, creates and perpetuates health disparities. So we're going to go over some of the first-line treatments for major depressive disorder. Note that a lot of these are also effective for other mood and anxiety disorders, PTSD, OCD, generalized anxiety disorder, panic disorder, and where kind of that becomes pertinent, or if there's a kind of a pearl in that, I'll kind of talk about that. Usually the differences just comes down between dosing, with anxiety disorders requiring higher doses typically. And then obviously we are dealing with people with HIV, so we want to be cognizant of any drug interactions with antiretrovirals, as well as any kind of things to think about in folks with HIV that may be related to virus or other things. So when I think about antidepressants, I think about what's first line and second line. And in a primary care setting, you're oftentimes really going to be thinking about the first line. Oftentimes when someone gets to me, they've been on one or more different first line medications, and which is great. And I want to make sure that you guys feel empowered to have kind of an understanding of all the different ones. SSRIs used to be considered the first line. That is not necessarily the case. I think SNRIs, as well as our atypicals nowadays, could all be considered first line. The good thing about this is if you were to put all of these on a roulette wheel and spin the wheel and you landed on one of them, more than likely you are going to have some effect on their mood, their symptoms in a positive manner. You may not achieve full remission, but you will probably have some improvement in symptoms. So kind of take some of the pressure away in terms of actually choosing these medications so that you can kind of get down into just like helping them. So SSRIs were the first of the new class of medications that came out in the late 80s, early 90s. They have generally replaced all of our older ones, MAOIs and TCAs. In general practice, and even in psychiatry, we tend to very rarely use MAOIs and TCAs. It also made primary care depression and anxiety symptoms or disorders much easier to treat for our primary care colleagues, because you don't have to remember all the horrible side effects and drug interactions and food interactions that these older medications have. The best thing for our patients is that these are effective and very well tolerated medications for the most part. And they have lots of different indications for both depression, anxiety disorders, PTSD, and OCD. We do always want to think about the anxiety spectrum, PTSD, OCD spectrums as requiring oftentimes higher dosing. And this becomes a little bit of a tricky thing because sometimes people who are going to be on these medications are going to also have a lot more side effects to some of the early side effects of these. There's an interesting phenomenon when we start an antidepressant, such as an SSRI, that people can actually get an initial worsening of the anxiety. And that becomes something that we see a lot of patients who say, every time I start an SSRI, it makes my anxiety so much worse. And that's true. They probably are making your anxiety a little bit worse. This is an adaptation of your brain getting used to them and everything. And the way I view it is it's almost like an akathisia-like symptom. It's just this increasing the serotonin is kind of increasing this like feeling of restlessness and anxiety. And the way that we do and mitigate that oftentimes is just really going low, starting at a low dose, maybe a baby dose, or even almost a homeopathic dose if we can, and slowly titrating up so that people get used to it. And when we talk about the specific ones, we'll kind of talk about the pearl of that there. So again, class-specific side effects for our SSRIs, this early initiation of anxiety, some of the nausea, especially early on, the nausea as you're kind of getting adapted to it. The big limiting factor that I think most people have is with these is the sexual dysfunction. So decreased libido, delayed orgasm, or anorgasmia, erectile dysfunction. These are all pretty common symptoms. In the vast majority of people, they do tend to improve. They may never go away, but they do tend to improve over time. So early on, you want to kind of give them the idea that this can potentially be problematic, but for most people, it tends to get better. And if it doesn't, we do have other options for this. Augmentation strategies, doing holidays off the medication for a couple of days, things like that can be helpful. Some of the most well-studied augmentation strategies include our PDE5 inhibitors. That actually works for both men and women. Interestingly, I do have several women on sildenafil for sexual side effects as well as tadalafil, and they do have benefit from it. So don't be afraid of using those in both cisgendered men and cisgendered women and our transgendered and gender non-binary patients. Bupropion, buspirone, and mirtazapine can all also offset the side effects of these sexual dysfunction, and as well as provide kind of boosting effect of the antidepressants. I'm a consultation liaison psychiatrist, so I think about everything in terms of all of our medical stuff. And the one that we think we tend to mitigate or downplay quite a bit is this understanding of the bleeding risk. So SSRIs do inhibit the SERT receptors on platelet, and it does actually cause decrease in platelet aggregation. So there is an increase in bleed risk. I think that we vastly underestimate the risk of it, especially when people are on chronic NSAIDs or warfarin or other anticoagulants. So the upper GI bleed risk is actually quite a bit higher, and concomitant use of NSAIDs, warfarin, or other anticoagulants can also increase that risk. So we just need to be careful about that. We need to kind of watch out for it, warn our patients on this. SSRIs and stroke, there's a lot of evidence to suggest in ischemic stroke that SSRIs are actually quite helpful and protective following a stroke. However, they really are contraindicated in the case of an intracerebral hemorrhage. So I worked previously on a post-stroke rehab unit, and I actually would avoid putting people on an SSRI if they had an ICH. If they were already on an SSRI, we do know that they still have a risk of repeat hemorrhage, again, especially in that first month after the ICH. However, you also want to make sure that you're weighing the risk of psychiatric decompensation if you were to discontinue it. Oftentimes, what I was doing on that unit would be stopping the SSRI and putting them on something like mirtazapine or even like a low dose of Seroquel, just to get them through that period, because both of those can have antidepressant effect, but less of a bleeding risk. So we want to be really careful about that. There is a post-operative bleeding risk as well. It is not suggested that we stop an antidepressant before surgery. However, it does have a little bit of an impact in terms of achieving hemostasis following the surgery. It's not significant. There's not any data to suggest it has increased morbidity or mortality to it. And so for our surgeon friends, should not be telling patients to stop their SSRIs. The other one that I really think about for SSRIs in terms of side effects is hyponatremia. I just had a patient yesterday who has sodiums that are like upper 120s, low 130s, who's at risk of falls because she has a metastatic process in her cerebellum, who I did not start her on an antidepressant. Her symptoms were moderate enough that she could have benefited from it. But after discussing with her the risk of hyponatremia, she and I both agreed that that was probably not the best idea for her, as she's already been having some falls. So hyponatremia is a big thing that we want to be considering for folks, especially older cisgendered women. But I have seen people of all ages have sodiums drop within that first 30 days of starting a medication. The elderly are more likely, but it's not always related to them. And when we think about this, the risk of hyponatremia and hospitalization from that is 5 times greater than that of the general population. So this is a significant side effect for folks. So anyone that's on a diuretic, especially more than one diuretic, really be kind of looking at that. Anyone who has history of hyponatremia or concurrent ongoing hyponatremia or any other kind of SIADH picture, just be kind of wary of that. And again, hyponatremia, even at normal sodium levels, if it's low, but still clinically normal, it still has the potential for fall. So I do worry about this for our older patients who are already at risk for fall. So I tend to do actually a lot of screening for fall risk when I see patients in kind of the geriatric range. So the SSRIs, there are 6 of them out there. This is in no real particular order other than just how I wrote them out. Citalopram, escitalopram probably are the most common prescriptions these days, with escitalopram being the #1 antidepressant in the United States at the moment. Sertraline, fluoxetine, paroxetine, and Luvox, or fluvoxamine rather, are all out there as well. In HIV, folks, I particularly like escitalopram and sertraline. In general practice outside of HIV, I like those plus fluoxetine. I do not like paroxetine or fluvoxamine. I don't like paroxetine, and one of my attendings and training said friends don't let friends prescribe Paxil. The reason is that if you have poor adherence to a medication, paroxetine is really, really awful in terms of its withdrawal effects. So some people get very bad withdrawal with paroxetine, and some people to the point where it's not even making it to the next day, and it's irritability and anxiety and just feeling cruddy that people are getting. So I tend to be really concerned about that. I also worry about paroxetine, not only from its withdrawal effects, but it's also pretty anticholinergic. So in our older folks, we really want to be careful. I always consider paroxetine to be like an SSRI and hydroxyzine. That's actually a good thing in some patients. And so there are a couple of patient populations that may be worth considering. So people with PTSD who have very good adherence are someone that could be considered for this, because a lot of the early studies after the Iraq War started were looking at paroxetine, and it does seem to have a little bit better benefit for PTSD. Also, our anxious and irritable depression phenotypes could be better for it with the kind of the early anxiolytic effects. Don't be fooled by the CR formulation. There is a controlled release or a longer release formulation of paroxetine. It does not significantly add to the half-life, and people do still get kind of the withdrawal effects of it. CR was kind of a marketing gimmick to begin with, where they were trying to go after vasomotor symptoms associated with menopause. I've really very rarely prescribed. If I've prescribed paroxetine, I'm very rarely even prescribing the CR. I tend to stick with the IR. Luvoxamine is this, unfortunately, an orphan SSRI at this point. It came about after sertraline, fluoxetine, paroxetine came about, kind of in that time frame, but didn't really separate out from those others. But it did add multiple different drug-drug interactions due to its CYP450 activity. So it's kind of not something I really prescribe very often. Its kind of claim to fame is, well, all of these others work for OCD, but they don't have an FDA indication for it. So we're going to go for the OCD indication. So that's typically where I see people prescribing it. It does not have any additional benefit in terms of treatment of OCD over paroxetine or fluoxetine or sertraline. It's just what it has. There was a little bit of a resurgence in fluvoxamine's popularity at the beginning of the COVID pandemic, because it does seem like it decreases hospital admissions and mortality early on in COVID infection due to some interesting antiviral properties. That kind of quickly fell away. I didn't really see much after that, because we started getting a lot better at treating active COVID. But there was a little bit of a blip early in the pandemic from that. When we think about these medications and we're thinking about antiretrovirals, really what I tend to focus on in our HIV population is escitalopram and sertraline as our SSRIs, because they tend to have the least number of drug-drug interactions. I don't prescribe that much citalopram anymore, other than it's just kind of legacy patients that are still on it because of the problems with things like QTC prolongation and then having to dose decrease potentially when someone hits 60, things like that. So escitalopram has kind of gone to be that's my first choice for most people. And otherwise, sertraline becomes my next choice for folks, especially in our HIV population. A nice thing about sertraline is it has a huge dosing range. You can start at 12.5, which is almost a homeopathic dose of this medication, and really get people used to some of the activation and that early anxiety, and slowly take them up over time to something like 100, 200, 300. That's a months-long process, but it does allow us to give you that kind of buffer to help mitigate a lot of the side effects, that early activation side effect that people get, and it makes them uncomfortable. The one downside of sertraline for me is that it tends to have the most sexual side effects of all the SSRIs other than paroxetine. So paroxetine is absolutely horrible for sexual side effects. Sertraline, at least on a population basis, seems to be kind of the second worst in that area. But it's still a very good drug that I prescribe a lot of. So fluoxetine, I don't prescribe a lot of fluoxetine in medically complicated folks. That tends to be mostly due to 2D6 inhibition, as well as just its long half-life makes it difficult. If someone's having some side effects from it, it's hard to get them off of it quickly. The big one in HIV, though, is with ritonavir, especially at higher doses of ritonavir, there have been case reports of people developing serotonin syndrome. I believe those doses of ritonavir are much higher than we use these days, but it's still possible. And even absent of that, use with ritonavir has shown at kind of more common doses these days have shown like cardiac and neurological side effects. So that co-administration with ritonavir and our kind of ritonavir boosted regimen seems to not be the greatest. Anytime that my drugs are decreased by an HIV medication, that doesn't bother me. I will just dose adjust around it. I tend to worry about my drugs affecting the HIV medications more so. I have options. I'm not worried about viral resistance and things like that. So I will move my stuff around to make sure that they are on an effective ART regimen. So nevirapine, I know we don't prescribe a whole lot of it, but if we are using it and we are getting decreases in fluoxetine doses, as a psychiatrist, I will change that. Fluvoxamine has a lot of drug-drug interactions. I didn't include a lot of these in there, but it does not play well at all with like protease inhibitors. So I just as a blanket rule, I don't prescribe fluvoxamine in our HIV population because of its just erratic inhibition of different P450 enzymes. Paroxetine also is another one, doesn't play well with protease inhibitors. Again, it gets decreased by ritonavir, but more worried about it with its problems with protease inhibitors. Sertraline, again, it says significantly decreased, like it's 30% or so decrease with ritonavir boosted darunavir. That to me is not a huge deal. I will dose increase around it. So for me, that's not a big deal. I don't worry about that drug interaction. And then citalopram, it doesn't have a lot of drug interactions. There's a warning on the labeling for citalopram that says if you use it with a 2C19 inhibitor, and that would be, in this case, efavirenz or atrovine, to dose decrease to 20 milligrams a day. And that's because 2C19 inhibitors do inhibit the metabolism of citalopram and potentially increase the relative dose. And there've been some case reports of citalopram with these things having some mild QTC prolongation. I don't worry too much about the QTC prolongation of citalopram. It's there as a black box warning. I follow the guidelines for it. But to be honest, I have way more medications that don't have a black box warning on QTC that I prescribe. I go over it with patients. Citalopram's black box warning was kind of a marketing gimmick to get people to go to escitalopram because they were losing their patents on it. It's a real thing. It exists, but it's not something I worry about too much in this case. And again, I don't prescribe citalopram a lot these days. I prescribe escitalopram more because you can get to a higher relative dose of escitalopram. It's a 2-to-1 dosing regimen. So if you think about the 40 milligrams being the black box label as maximum for citalopram, with escitalopram, you go to 20 milligrams of escitalopram. That's roughly equivalent to 40 milligrams of citalopram We also can go over that to 30 milligrams even, so I can get folks over that dose, that relative dose, and not have to worry about it, because the R enantiomer is the one that seems to be most associated with QT prolongation, not the S enantiomer, that is S-citalopram. So our SNRIs, again, I think about these as first-line treatment options for depression, for PTSD, for anxiety disorders, things like that. But they do also add some benefit in terms of modulating pain response. So anyone that has like a comorbid fibromyalgia, complex regional pain syndrome, pelvic floor, chronic urogenital pelvic pain syndrome, or other kinds of urogenital pains, migraine headaches, cluster headaches, and neuropathic pain, these medications tend to be really good at modulating that pain. So they're good, but we're adding a different neurotransmitter. We're adding norepinephrine to it. So we're going to be increasing some of the adrenergic drive in our body. So we do have some concern about hypertension. It does seem to be dose dependent, but I do monitor closely when I'm using an SNRI with hypertension. I've seen hypertensive crisis even at like 30 milligrams of duloxetine. So you got to be careful with it. Urinary hesitancy and retention are possible. Tends to be worse with duloxetine and levomilnacipran. Duloxetine actually has an FDA indication for overactive bladder. So in some people, the urinary hesitancy and retention is a good thing because it kind of slows things down. And the other one that can be rate limiting for a lot of people is just diaphoresis. Anything that time you're kind of increasing norepinephrine, you're going to potentially increase some diaphoresis. So I have people that have had to stop it because of sweats and things like that, especially night sweats from it. There are currently 4 FDA-approved SNRIs for depression. Milnacipran is out there as well, but it's only for fibromyalgia, although in the European Union, milnacipran is also approved for depression. I have never once prescribed levomilnacipran. I know it exists, just never prescribed it. I tend to stick with duloxetine, desvenlafaxine, and venlafaxine. Venlafaxine kind of is the prototypical one. The kind of downside of venlafaxine is it is a little bit of an odd duck in that at lower doses, it doesn't have much norepinephrine reuptake. So you have to start getting up to higher doses to really have that norepinephrine reuptake inhibition. Otherwise, you're just kind of giving someone an SSRI. Its other issue is it has a really short half-life. Biggest problem with venlafaxine is it's almost like paroxetine withdrawals, but you've stuck your finger in a light socket. So it has almost invariably patients will say, I'm having zaps with this. If they stop taking the medicine, if they miss the medication, they start getting these kind of weird electrical zap sensations, primarily within the trigeminal distribution, but it can happen all over the place. And that becomes very difficult to get people off of this. So not only do you have the kind of short half-life making you irritable, you're also irritable and being a little bit of electrocuted. To get people off of this, I actually just cross them over to fluoxetine or Prozac to try to give that longer washout period to help, and that seems to be helpful for them. That being said, it's still a good medication. Adding mirtazapine to this has a unique benefit. It kind of seems like it's almost supercharges both of them. So if you're at a high dose of venlafaxine 225 and a high dose of mirtazapine, some of the studies that have been shown have shown it to be almost as effective as an MAOI without the MAOI dietary and drug restrictions. So definitely something to consider. I do prescribe venlafaxine for folks, but I do worry about that with the side effects. Desvenlafaxine is the active metabolite of venlafaxine. It's newer. It seems to be a little bit longer half-life. It's found in more stable plasma concentrations, and it doesn't have that kind of withdrawal effect that venlafaxine seems to have. So I've been prescribing this more and more for folks, and people tend to do well with it. Interestingly, there's not that much evidence of support going to 100 milligrams. Most people do well at 50, and they don't gain much additional antidepressant effect by going higher. So I do keep that in mind for folks on this. Main thing right now for desvenlafaxine is just coverage issues. Duloxetine is my go-to for pain. Patients with any kinds of pains, I really do go with duloxetine as my first option for those guys. It seems to have the best evidence for use with kind of minimizing the side effect profile of it. As an antidepressant, if you just had depression and you don't have a chronic pain condition, like headaches or fibro or anything else like that, I'm probably not going to give duloxetine just because it's not as good of an antidepressant in those cases. It tends to be good for anxiety, not quite as good for like major depression, things like that. But really, really thinking about this for pain, especially peripheral neuropathy, as it's equal to gabapentinoids, although it kicks in a lot quicker in terms of managing it. Like I said, I rarely prescribe levomilnacipran or Fetzima. I don't think I've ever prescribed it once. So can't really give you much on that other than from a side effect profile, it has the strongest norepinephrine to serotonin inhibition. So it has probably the highest side effect profile, including urinary retention is a big one for this. So be careful on that one. So go kind of quickly over antiretrovirals. Does venlafaxine in theory should decrease the concentration of protease inhibitors? That is a very theoretical side effect. I'm not entirely sure it's been demonstrated in anything other than Antidepressant. I wasn't able to find case reports out of that. Do worry about duloxetine with folks that are on ritonavir, and you do want to be careful. Duloxetine does have some hepatic toxicity in and of itself. It's absolutely contraindicated with anyone with hepatic insufficiency or significant transaminitis, things like that. And so I really use it in caution with anyone with like active hepatitis, HCV infection, or if you're using it with like protease inhibitors or other kind of older like NRTIs and NRTIs that have more of a hepatotoxicity risk for it. So does limit its use there. It also kind of limits its use in folks with like significant alcohol use disorder because I do worry about its potential hepatic toxicity there. And then levomilnacipran is a 3A4 substrate. So if anyone's on a boosted regimen, we want to be careful. So if anyone's on like ritonavir or cobicistat boosted regimen, and they're also on levomilnacipran, be really careful, especially since people already have a lot of kind of underlying risk for intolerance to this due to its kind of more negative side effect profile.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.